And those are the people we take care of. And we need to know what to tell those people.
So, Sarah, you're right on target. And so one of the challenges to date has been the tension between the number of data elements and the burden of collection versus the need for the data elements. Well, it turns out for the TVT registry, all of a sudden the issue of frailty comes into play. In the issue of left main PCI, all of a sudden the issue not just of surgical refusal comes into play. None of those data elements have been in our registry up to now because the registries were standalone. Guess what the next version is going to have to incorporate? Now, the other thing is we've wanted to use Spertus's Seattle Angio Questionnaire, the Kansas City heart failure determination. And again, it's the issue of burden of collection. However, the Kansas City is going to be required in the TVT registry. So we'll have that data at least for 1 year, and then in the post-approval studies long term. The hardest one is the, and the quality of life. That's actually it's mandated to be required. To be. And the last part is the issue which is a great point about how most of these registries are diseased, episodic-based, hospital-based, in that we need to have longitudinal follow-up. The burden of collection and the expense is huge, but we've come up with a strategy where you merge the clinical data at the time of admission with longitudinal administrative data that you can get with repeat hospitalizations, which is not perfect, but it turns out to be a very powerful tool. So the ACCERT grant, looking at longitudinal care, was utilizing that strategy with medical data. And Providence Health System could do the same, merging the NCDR data with their administrative data related to readmission, so you actually could figure out what's best. So those are great comments.
I've been in practice here for 35 years, both as an interventional cardiologist and an invasive cardiologist. And over the years, I filled out many forms in the cath lab, do a Pinnacle or whatever. And Oregon has always been one that puts on these studies. We always have great outcomes. But the problem is the reimbursement for physicians in the state of Oregon is very limited. So here we are going through this drill again here in the state of Oregon when there's other part of the countries that don't use it at all and abuse it. So how is the American College of Cardiology going to rectify other parts of the country having better reimbursement than we do when we have the outcomes?
Ha 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 ha! What did Shakespeare say? First, shoot all lawyers. But I won't. Obviously, Florida. Well, let's speak to Florida. I want to avoid getting personal in my own philosophy of care, but the bottom line is. And what we've been working on with Congress and the agencies like MedPAC that adjust fees and give recommendations to CMS on how to adjust that fees, that physicians basically want to do what's right. And for the most part, when they get their data and they see their data, they will change. But if you expect them to change by how you pay them, they will find a way around the problem. Especially if we can talk about McAllen, Texas, and what Atul Gawande said once you get into the business aspects of the sides that become and trump the care aspects. So our approach is doing what Dr. Brenda says, is get the data there. Let me give you maybe two examples of what can be done and how things can be done. Turn this back to the NCDR. A hospital in Maryland had a very aggressive cardiologist. He got a pig roast for doing 32 stents in 1 day. That hospital, a member of NCDR, never looked at the data, didn't do anything with it. They ended up settling a qui tam with the surgeons for $24 million, and that cardiologist is probably going to go to jail for Medicare fraud, and the hospital just took a blind eye. Another hospital system now down in Florida, Morton Plant, actually took the NCDR data. They reduced their variation in the cath lab, improved their outcomes, reduced their mortality, improved their appropriate use criteria, improved their efficiency, and actually made money on that. And now they want to get down to the physician data so they can find out who the outliers of the physicians are. But it ended up being revenue generating for them instead of revenue neutral. So there are ways of doing it and improving the things. Obviously, that it isn't, what we're going to be looking at is going to be more of what you're doing in Oregon applied across the country. Now, how we get to that is going to be, there's going to be some difficulty and some pain. I'm not going to say it's going to be wonderful for everybody, but you're ahead of the game, and what's going on, what Sandy's mentioned, and Oregon's definitely ahead of the game.
So I totally agree with your comment, and I think the challenge is coming up with physician payment reform that is aligned with these quality measures, aligned with the goals of decreasing costs. I haven't seen much talk. I think what you might be referring to is true gain. If there's sharing, if there's savings, is there gain sharing going on with the physicians? These type of models. Of course, we have some leaders in physician payment reform models right here in the room. I don't know if you wanted to, I put you on the spot. Do you want to talk about some ways that we can answer those concerns?
Thank you, Ralph. My name's Cheyenne Huang. I think I've preached to many of you already, so bear with me a little bit. At Providence, we've been working with trying to engage payers, whether it's through Providence Health Plan and Care Oregon or other payers, to figure out, can the payer reward us and those of us who provide value-based care to our patients, to our mutual patients. So if we, by doing the right things and improving quality and lowering cost and saving for the payers, can the payer somehow share some of that with us and distinguish Stuart, those of us who do it right versus those who don't. So that's been ongoing, and we hope to get more of your support.
And again, I have to be a little careful about getting ahead of the game here, but when we do actually have the quality measures worked out, there's going to be probably coming up a differential payment for quality. It won't be the tiering that occurred after the HMO era where they tried to tier, and that the tiering was all done by who actually charged less. It wasn't necessarily quality, but you'll be tiered by quality. You'll get differential payment if you're doing quality work, and you may see a penalty if you're not doing quality work, and that's going to be, you'll probably see that. But I think we need to get the physician report, the hospital report. It has to be accurate. It has to be adjudicated. It has to be actionable. You have to figure out who's responsible for the patient. It has to be risk adjusted. All those things, and that's where the fact that Ralph and the guys that are, I call them the quality mafia, are so far ahead of the game in helping us position cardiology to be ready for that world.
Bob, you want to give a response?
Yeah. Well, it's actually just to add something, from the payer perspective. One thing I really want to make sure that I make clear is that the desirable or goal rate of inappropriate use, or now termed rarely appropriate use, is not zero. And I've heard that CMS in some states was not going to pay for procedures that met inappropriate criteria. I don't know if that's been, but yeah, but I think that what I'm interested in and what this is about is looking at the variation and looking at how can we explain that, and if there's opportunities to reduce the variation, to concentrate on that. And if we've lost the ability to build trust, we've lost a lot, because the leadership is going to have to come from the profession. And we also are going to have to be intellectually honest about low-value care, because one of the comments I heard earlier is about uncertain doesn't mean it's wrong, which is true, but it also doesn't mean it's right. And if there's variation around uncertainty, there are some areas where, especially on the imaging side, and I was talking to Ralph about this, and it takes steps to get through some of this, But there's some areas in the uncertain criteria on imaging where I think most clinicians would agree the value is unlikely to be of benefit. But what happens is that there's no evidence to show that it's wrong. We need to come together about being honest about where's the value likely to occur. Patient preferences are important, and I recognize that, but patients can't be misinformed about the actual opportunity that's being provided to them by a test or by a procedure. They need to have accurate information. And if there's variation in communities on patient preference, then I think that there needs to be some assessment or skill building on how to transmit information. Because and minor variation is also not something I can be concerned about. There's going to be minor variation. But twofold or threefold variation, and not in Oregon. We're not tenfold in Oregon. We're starting in a lot better place. And the fact that everybody's here today speaks to their commitment to trying to get better yet. We're ahead.
Thank you. Ty, I had asked you to give us some comments. Do you want to take a couple minutes?
So I didn't prepare anything, but I think some of the points that I was going to espouse this evening have sort of been outlined already. Sure. I'm Ty Gluckman. I'm a non-invasive, non-interventional cardiologist at Providence St. Vincent. And I think to the points that have already been brought up, actually, I send people to the cath lab, but the responsibility really doesn't lie with the interventionalists. In fact, all this should occur upstream prospectively, and I probably bear just as much responsibility, if not more, for assuring that appropriate revascularization is performed. And I think we have to start thinking about proactive ways to collect that data. One of the questions that I want to reserve for Ralph and maybe Jim as well is, it's a challenging thing actually working, and Sanjeev, you brought this point up and others have as well, in terms of incorporating data that we have through electronic health record systems that should allow prospectively to be able to calculate everything short of the coronary anatomy and be able to plug in one variable and spit out information such that prior to the timeout, you're looking for one variable, you have that last variable, and you can make an educated decision on the fly. And in fact, to a large degree, I would bet that most, maybe not most, or a sizable minority of the time, we have interventionalists who are flying blind. They don't have the data. They're not aware of the data. The data may not even be accessible, and or we don't have an integrated electronic record that allows them to be able to capture that data. And so an educated decision that doesn't involve shared decision making, because the patient's on the table, is often made in an impromptu fashion for these individuals. I will say that there is work at the ACC to try and improve upon this process, but from what I've been told, actually working with several large EHR vendors, is often their allegiance is to the client, which is the facility or whoever pays the bills, and it is a challenge, having worked with a lot of different people, even through ACC National, to try and engage EHR vendors to make your life easy, even if the data could be there, to be able to do it in a way. And it seems intuitive, but a lot of people who talk, whether it's in nuclear regulatory area or in business, how far medical informatics is behind the time of where we sit in a lot of other disciplines. And a lot of people say it's not complicated. It should be able to just input the data that exists overall. I will say also that there is a lot of work on a national ACC level through the health IT committees in terms of trying to generate standardized not only data definitions, but also discrete data variables that actually get inputted into EHR systems so we can talk in a more uniform fashion. And I had a recent conference call about 3 weeks ago with Jimmy Chang, who's the head of the cath lab at Duke. He is actually co-chair of the Health IT Committee for ACC National and is really doing some work. And I would say it's probably not too far in the future, in the next several years, where you'll see ACC roll out some discrete data forms where there's encouragement to actually report your cath data, your imaging data, in specific regulated forms that feed into these registries, but also allow a very robust way to collect meaningful data, assuming the data is still inputted correctly, and to be able to calculate appropriateness, but also be able to just help to serve our registries so that really there isn't much abstraction that goes on. It's just as reliant upon ensuring that we have those engaged champions. The other thing Sandy asked me to talk about, and I think it's a difficult thing at different institutions, is I think it really requires a dedicated responsibility by the individual institutions to find those champions who really want to see this through. And it is time consuming, and setting up quality initiatives on a local level, on a regional level, on a state level is really challenging. But I think the time is upon us that really is something that institutions, healthcare systems need to take a strong responsibility to do. And I think in Oregon, we're preaching to the choir. Stu, you brought up some of these issues, but I think we're preaching to the choir here. But when you go around this country and you talk to people in different institutions in different regions around this country, there are a lot of hospital systems where providers, when you ask, have you seen your data, most people don't raise their hand. They don't have engaged champions. There are sometimes adversarial relationships amongst different groups at a given institution, and it poses a lot of challenge for actually trying to move forward quality initiatives for data collection, move through quality initiative programs. The final thing I think that's important to talk about, and I think it's the next step, we've talked about all these baby steps that are really still big steps is, and Ralph and I talked about this at the recent ACC Oregon Symposium, but there's a question of how accurate the data is in terms of even reporting coronary stenoses. And you look at states like Maryland, which is a heavily regulated state that several of us in this room left several years ago. I left almost 7 years ago. And more there are now requirements for outsourcing independent reviews of the coronary angiograms and actually looking at the data in a blinded fashion, but being done where the responsibility is actually dependent upon the individual institution to pay for that process. There are now through ACE, and there are programs that are coming forward for cath lab accreditation. They are expensive, but nonetheless, they try and bring this to the forefront of really trying to make sure that not only the data that we're reporting out is accurate, but that last fifth final piece that enters into the appropriate use calculation, that really the coronary anatomy is what it says it is. And I think part of the problems that have come up, and knowing some of the individuals involved, what happened in Maryland, is actually having accurate reporting of the actual data when you calculate it, that it's actually true. And so I think there's a lot of stuff upon us. I think we, from a quality perspective in the state, are well poised because of all of you who are in the room here tonight. I think as we move forward, we need to start thinking how we move towards this. Accountable care may move us there very fast, but I think it's an exciting time, but I think it's also a challenging, and in some ways, as Stu brought up, a frustrating time for a lot of us as well, and how we leverage our EHR systems, how we leverage quality initiatives in our healthcare systems to really do more of the dirty work for us and really take the responsibility away from a lot of people who do data abstraction to really do it on the fly rather than after the fact. And that's really also all I wanted to talk about. I think there's still probably questions that people have. I don't want to keep people here from a prolonged, indefinite period, but I want to say, I do want to say that the one final thing about this, and I will say, having been involved, and Ralph's a testament to that, is the ACC, and I don't want to get on a soapbox here, but I really do think it's your organization, and it requires a commitment that often is not reimbursed, is volunteer time, but it's really important. And I think the organization is extraordinarily receptive at a state level, and in addition at a national level, to having any of you who want to get involved in committees or different parts of the organization that are interested in moving these quality initiatives forward. They're always looking for people with good ideas who are willing to volunteer their time, but also really add their 2 cents. And I can speak to that personally. You both can speak to that in a much better sense than I can. But I would say if any of this gets your juices flowing, gets you excited, there are opportunities for you to be able to participate, whether it's through NCDR, ACC, locally, or nationally. So there you go. You took a job. So you found the easier way to deal with it. So.
Jim is actually a reformed pediatric cardiologist.
No. It's known as blowing a disc in the middle of a cath and losing sensation in your hands and saying, okay, enough of this clinical stuff. I want to answer Stu in a different way. I was kind of talking about where we're going in the future. Right now, our approach is to make sure that we provide for the cardiologist to handle the patients in whatever setting they're in the best way they can in that setting. So we want to support the care, whether it's an integrated system, whether it's a Geisinger type model that's in an ACO, whether you're in a onesie twosie type practice, but to make sure that we keep the practice viable and the care of the patients. So what we're doing for each is a whole spectrum, but I was kind of talking about where I think that the healthcare system is going to go because of the costs that are involved right now, and the major aspect of the deficit going forward is Medicare and Medicaid. It's not defense, it's not discretionary bet, and it's not Social Security. That's secure.
I just want Rich Rom to start thinking about, I want him to explain, he's the quality something at Peace Health, and I'd really love to hear what they're doing while Sarah asks her question.
This isn't a question, it's just a sort of observation. I think you guys have a real opportunity here to start telling your stories, and I think you need to work with Jim and Ralph and others at ACC to figure out how to do the PR to tell the different story that's happening here. And you need patient stories, and you need physician stories, and you need to make them personal. And you need to work with PR people, and you need to get the message out, and you need Sandy's data and Ty's data, and you need to present it. But if it's different here in Oregon, nobody knows about it except for people in Oregon. And so I really think that this meeting ought to end by people figuring out how to get the message out and how to work with the press and how to work with other entities to tell the Oregon story.
You may.
The variance that we see between hospitals, you know, A, B, C, D, E, and F and G hasn't really been addressed. So could we talk about that and why there's the variance? Do we know why?
Do we know why?
So, Bob, I don't think all of your data was demonstrated, and none of this has been unblinded, but I think part of this, and I would welcome you inputting as well, there was a trend. We had seen a slide that had been presented at our ACC Oregon Symposium to some of the counselors that even for those where there was more divergent variation in terms of appropriateness, those numbers started coming down. And I think part of this is just an awareness of the data. And I think to Jim's point, and I really do believe this, although there is gamesmanship that will always go on, I think this is really the minority of providers out there because people genuinely want to do the right thing. I also genuinely believe that a sizable proportion of people out there, even talking with Paul Chan when he presented his data initially, is some of those people out there are just not aware of the data.
The only study that I can think of was Pam Douglas looking at nuclear studies and stress tests, imaging stress tests, in a population and going by quartiles of how often it's done. And